Dear students, we are into the second part of the topic Down syndrome. Now we are discussing about the clinical features, a distinct facial appearance. So the face is of a Down syndrome child is totally, it's a typical Down syndrome Mongolian face will be appearance. Flattened facial features. The face will be flattened. Small head, short neck, protruding tongue, upward slanting eyes, unusual for the child's ethnic group, usually shaped, usually unusually shaped. The shape of the ears will be unusual, and epicanthal folds means that is epicanthal folds means small skin folds on the inner corner of the eyes. So that means that the nasal area will increase and small epicanthal folds on both sides of the eyes, the middle border, leading to show the distinctive shape of the eyelids also. Excessive space between first and second toe, the lower limb, the first and second toe, there's a larger space between first toe and second toe. Large tongue in relation to the size of the mouth. Large tongue in relation to the comparative to the size of the mouth. Poor muscle tone, muscle hypotonia, low muscle tone. So poor muscle tone, that is what we call as muscle hypotonia, as well as low muscle tone, broad short hands with single crease. If you check the hand of a child with Down syndrome, you may notice that the palm does not have any palm lines or what you call as creases. Only single line will be there, single crease will be there in the palm. And relatively, if you see the fingers as well as the upper limb and the upper limb, the forearm and all, comparatively shorter forearm, shorter fingers, and they show throughout the body, as we already told you. I told you that poor muscle tone, that is low muscle tone, what we call as hypotonia. So because of that, what will happen, that muscle tone is less, so because of that, and ligaments are also lax. So ligament laxity and low muscle tone leading to excessive flexibility, which is another danger. There is a chances of dislocation of the mini joints, especially very common joint is atlanto axial joint. That is also commonly seen. That is a very severe problem because of the laxity of the ligament that happens. Infants with Down syndrome may be of average size, but typically they grow slowly and remain shorter than other children of the similar age. In general, the developmental milestones, such as sitting, crawling, occur about the twice the age of the children without impairment. So normal, if you compare the milestone with of a Down syndrome child with that of the normal child, it will almost be double, twice the age it will be required to reach the particular milestone. Children with Down syndrome also have some degree of intellectual disability, most often in the mild to moderate range. Intellectual disability is the lack of intelligence. Intelligence quotient score will be far lesser. Complications associated abnormalities. So what are the complications and the associated abnormalities? Children with Down syndrome can have a variety of complications, some of which become more prominent as they get older, including heart defects. Approximately half the children with Down syndrome are born with some type of congenital heart diseases such as ASD, VSD, PDA, tetralogy of Fallot, transpositions of arteries and vessels. These are kind of congenital heart diseases are also seen as an associated problem in children with Down syndrome. These heart problems can be life-threatening, as already you know about these conditions, and may require surgery in the early infancy so that the child will have a longer life. Another problem is leukemia. Young children with Down syndrome are more likely to develop leukemia than are other children. Infectious diseases. Because of the abnormalities in their immune system, those with Down syndrome are much more susceptible to infectious diseases such as pneumonia. Continuing the complications, the other complication is, or the associated abnormality is, dementia. Later in life, people with Down syndrome have a greatly increased risk of dementia. Signs and symptoms of dementia often appear before the age of 40 in people with Down syndrome. Those who have dementia also have a higher rate of seizures. Sleep apnea, because of soft tissue and skeletal alterations that lead to obstructions of their airways, children with Down syndrome are at a greater risk of obstructive sleep apnea. So this is also another life-threatening problem. Obesity. People with Down syndrome have a greater tendency to be obese than does the general population. Other problems of Down syndrome may also be associated with other health conditions including gastrointestinal blockages, thyroid problems in female, early menopause, seizures, hearing loss, premature aging, skeletal problems, and poor vision. See, all this may be present. Most of the time, if you see in a severe conditions, all of these are present. So you understand how difficult the life of a Down syndrome child is. Life expectancy, lifespan has increased dramatically for people with Down syndrome. In 1929, a baby born with Down syndrome often didn't live to the age of 10 years. Today, someone with Down syndrome can expect to live to 50 or beyond that, depending on the severity of his or her health problems. What are the early interventions? Early interventions for the infants and children with Down syndrome can make a difference in realizing their potential abilities and in their quality of life. Early intervention programs vary from state to state, but they usually involve the therapist and special educators whose goal is to help the baby develop more skills, motor skills, language, social skills, and self-help skills. So in the early intervention, these kind of activities, motor skill activities, language, social skills, and self-help skills will be useful. Here is a comparison of developmental milestone. Here on one side, we have the activities on the left side, and then the milestone of a Down syndrome child of the same activity, and we are comparing that activity with the typically developing child. So the typically developing child's, how many months do they or years they require to achieve this activity? So here see gross motor activity sitting alone, 6 6 to 30 months for a Down syndrome. Here normally developing 5 to 9 months. Crawling 8 to 22 months required for a Down syndrome child. 6 to 12 months. Standing alone, 12 to 39 months for a Down syndrome, whereas normally 8 to 15 to 17 months. Walking alone 48 months, 12 to 14 months for a Down child. But for a normal typical development, 9 to 18. Language, coming to first word, first monosyllable, 12 to 48 months, too much time it takes, 8 to 23 months. Two word phrases, 2 to 7 years. It takes 2 to 7 years to make a sentence for a Down syndrome child. It's too long time to speak a two-worded sentence. Or here normally it is between before 15 to 32 months. Personal social responsive smile. Social smile for the child is, it takes up to 5 months. For the normal child it is within 3 months. Finger feeding 10 to 12 24 months for the Down syndrome child, 7 to 14 months for a typical developing child. Drinks from cups 12 to 32 months, here it is 9 to 17 months. Use a spoon, using of spoon in for Down syndrome child, 13 to 39 months, 12 months to 20 months for a normally developing child. Bowel control 2 to 7 years, 16 to 42 months for the normal child. Dressing, that is actually the ideal dressing self. It takes almost 3 to 8 years for the child to dress him or herself. For normally developing, 3 to 5 years. coming to physiotherapy, children with Down syndrome want to do what all children want to do. They want to sit, crawl, walk, explore their environment, and interact with the people around them. To do that, they need to develop their gross motor skills because of certain physical characteristics which include hypotonia, low muscle tone. I told you, ligamentous laxity, that is looseness of the ligament that causes increased flexibility in the joint leading to subluxations, and decreased strength. Children with Down syndrome don't develop motor skills in the same way that typically developing child does. So, what are the problems? Physiotherapy is a requirement for the above said matter. So they find ways to compensate. The kids with Down syndrome find ways to compensate for the differences in their physical makeup, and some of the compensations can lead to long-term complications such as pain in the feet or development of an inefficient walking pattern. The goal of physiotherapy treatment goals for these children is not to accelerate the rate of their development, as usually people think, like usually even physiotherapists believe that the goal of treatment in for a child with Down syndrome is not to accelerate the development milestone or the accelerate the development process as such, but it is actually to facilitate the development of optimal movement patterns, because we don't want the child to learn movement patterns which are abnormal. So we want to stabilize each gross motor skill or fine motor skill, so that the movement becomes in an optimal pattern. This means that over the long term you want to help the child develop good posture, proper foot alignment, an efficient walking pattern, and a good physical foundation for exercise throughout their life. So, what and all can be done? So, the therapist, physiotherapist, also, along with the occupational therapist and the speech pathologist, because it is a teamwork. In the case of Down syndrome, they have all kind of problems. They have intellectual disabilities also. So, physiotherapist alone cannot do the magic. Assist with oral motor feeding problems. This can also be addressed by speech pathologists due to hypertonia and weakness of the muscles of the cheeks, tongue, and lips. Feeding becomes difficult for some infants with Down syndrome. So, occupational therapists also suggesting positioning, feeding. Physiotherapists can also do those, suggestions for positioning and feeding techniques, and can be involved in doing feeding studies. That is mostly done by the occupational therapists, helping facilitate motor milestones, particularly for fine motor skills. Occupational therapists and physical therapists work closely together to help the young child develop gross motor milestones, example sitting, crawling, standing, walking. And the occupational therapists work with the child at this stage to promote the arm and hand movements that lay the foundation for later developing fine motor skills. The low muscle tone and loose ligaments at the joint associated with Down syndrome are real challenges to early motor development, and occupational therapy can help your child meet those challenges. So, what are the approaches? Physiotherapy approaches which are very useful for a child with Down syndrome. As all of you know, the roots approach, according to Margaret Root. The here we are going to look to first most of the techniques. Here we want is here the facility. Here it is hypotonia. So you want to create stabilizing techniques. You want to improve the muscle tone. So all the approaches which are used as a facilitator technique, and as well as to promote the muscle tone, as well as to stabilize the joint with a proper pattern, all the techniques used by Margaret Roots is same way it is applied here for the Down child also. Neurodevelopmental therapy, same way. What at all gross motor and fine motor skills are lacking, and those kind of here we are not bothered by primitive reflexes or such things, such as spasticity and all. So we don't look into those kind of reflex inhibiting posture. We don't do that. We only look for therapeutic handling techniques. We don't apply the reflex inhibiting posture here. We don't need to do that. Only thing we take from the NDT technique is the what you call therapeutic handling techniques. So any handling technique which you use should be therapeutically beneficial.